of the origin. We have nothing new to say on the question of the origin of these dispositional hypnoid states. They often, it would seem, grow out of the daydreams, which are so common even in healthy people, and to which needlework and similar occupations render women especially prone.
So what he's saying is that when you are doing something which is very mechanical and you are in the situation of a daydream, such fantasies which can turn out to be traumatic, they seem more probable to occur in those states rather than in states where you are fully aware and awake and concentrated on something. So the more aware and concentrated you are on something, less is the possibility of any such affective event happening in the mind that it can result in a hysterical symptom. Yeah.
Why is it that pathological associations brought about in these states are so stable, and why they have so much more influence on somatic processes than ideas are usually found to do? These questions coincide with the general problem of the effectiveness of hypnotic suggestions. Our observations contribute nothing fresh on this subject, but they throw a light on the contradiction between the dictum hysteria is a psychosis and the fact that among hysterics may be found people of the clearest intellect, strongest will, greatest character, and highest critical power. This characterization holds good of their waking thoughts, but in their hypnoid states, they are insane, as well as we all are in dreams. Whereas, however, our dream psychosis have no effect upon our waking state. The products of hypnoid states intrude into waking life. I keep saying walking life. Waking life in the form of hysterical symptoms. What we have. Oh, she's here.
Yeah. Can you hear us, Adi?
Yes, sir.
Okay. So in this paragraph, he says some important things. First element is, if you are in a state of high concentration, high awareness, high ego strength, the chances that in that state an event which occurs in the mind can turn traumatic, the probability is very low. If you are in a state where because of past events you are already fragile, let us say for example you are passing from a series of losses, say you break up with two friends of yours, then you have a quarrel with your parents, and then you have a quarrel with your teachers, and then one more friend leaves you, and when the last friend leaves you, it becomes traumatic. And then you can say that it is only because this happened in a series that the last event became traumatic. If this event had happened on a standalone basis, where I was in a steady state, I would have easily handled this issue. I would not have crumbled before this issue. It was only because I was in a state already fragile because of the last three events that I could not handle the fourth event. Okay. So the first point he makes is that there is a state element. If you are in a state of high awareness, high concentration, chances that you will develop something traumatic in that state are less. Second, we can extend the argument to say, if you are in a state of high ego strength, in a state of positivity, in a state of good experiences for the last few days, again the chances that you will get traumatized are less. Then he says, hysteria, right, is not a psychosis. How can you make the difference? Hysteria is not a psychosis, he says. How do you make a difference? He says, among those who suffer from hysteria, we can find people with greatest character, greatest critical power, and clearest intellect. So the first is, there is no question of a universal psychosis. Even if we are dealing with one, it's a circumscribed one, number one. Number two, even in that circumscribed area, it is not a psychosis because it is a disassociated state where, like in dreams, insane elements come out. So it is like somebody has an episode of dreams while wide awake. And third, he says very importantly, that therefore hysterics are not psychotic. It's a neurotic problem. And the fourth he says is, it is like a dream psychosis, which we all have every day. So all of us go into almost a psychotic state every day in our dreams. The difference between us and the psychotic is that our going into the psychotic state and whatever happens there does not have much influence in our waking life. We don't confuse reality and fantasy, which the psychotic confuses. Yeah, we can go on. What we have asserted of chronic hysterical symptoms can be applied completely to hysterical attacks. Charcot, as is well known, has given us a schematic description of a major hysterical attack, which according to which four phases can be distinguished in the attack. One, epileptoid phase. Two, phase of large movements. Third, the attitudes of the hallucinatory phase. And fourth, the terminal delirium phase. He derives all those forms of hysterical attack, which more often than not met with more often than not complete grand attack from the abbreviation, absence or isolation of these four distinct phases. We don't have to go into this because we don't get so many patients, but these are the phases that he has seen there. The first phase of onset, which is slight conversion. Second phase of large and often sexually suggestive movements. Third, the phase of hallucination and the phase of delirium. Okay, so in his description and their experience of that time, this is how the attack used to proceed in four phases. Today we neither find hysteria so widespread, and even in case of manifestation, it is not necessary that this sequence should always be followed. Okay? But this is the summary of their general experience of that particular time. Yeah, can anybody read our attempted explanation?
Should I read?
Yeah, please.
Our attempted explanation takes its start from the third of these phases, that of the attitudes passionals, where there is present in a well-marked form. It exhibits the hallucinatory reproduction of a memory, which was of importance in bringing about the onset of the hysteria. The memory either of a single major trauma or of a series of interconnected part traumas. Or lastly, the attack may revive the events which have become emphasized owing to their coinciding with a moment of special disposition to trauma.
So we see
There are also,
yeah, please go on.
There are also attacks, however, which appear to consist exclusively of motor phenomena and in which the phase of attitudes passionals is absent. If one can succeed in getting into rapport with the patient during an attack such as this of generalized clonic spasms or cataleptic rigidity, or during an attack they somnale, which means attack of sleep, or if better still, one can succeed in provoking the attack under hypnosis, one finds that here too there is an underlying memory of the physical trauma or series of traumas, which usually comes to our notice in a hallucinatory phase.
So we see here that the third phase, the most important phase for psychoanalysis, in fact, the second phase also is very important, although he's not referring to it, because often in the second phase, what was seen at that point was very histrionic bodily movements which were erotically suggestive. And then he talks about that the whole point is getting into the root of the psychical trauma which is underlying this entire four-phase event. And he says in the third phase onwards, he has been able to get into rapport with the patient and find that underlying that whole problem is the memory of a psychological trauma or a series of small traumas. So we have two situations, one big trauma leading to hysteria or many small traumas coming together leading to hysteria.
Thus, a little girl suffered for years from attacks of general convulsions, which could well be and indeed were regarded as epileptic. She was hypnotized with a view to a differential diagnosis and promptly had one of her attacks. She was asked what she was seeing and replied, the dog's coming. And in fact, it turned out that she had had the first of her attacks after being chased by a savage dog. The success of the treatment confirms the choice of diagnosis.
You can see here how you can see here how a girl had convulsions, and the convulsions started after she was chased by a savage dog. So this became the traumatic event. How do you link the two? The being chased by a savage dog is the traumatic event. Convulsions is the hysterical symptoms, and the two are linked. After the traumatic event, the general convulsions started, and you can see the general convulsions, nobody can make out by looking at the general convulsions, which look like epilepsy, that they can be associated in any way to a psychological problem, and that too, the fear of a dog. Nobody can make it out unless you go into the history of the person himself. And this is what is being done here by hypnosis. Still early Freud, who was using hypnosis and not yet using free association completely.
Again, an employee who had become a hysteric as a result of being ill-treated by his superior suffered from attacks in which he collapsed and fell into a frenzy of rage, but without uttering a word or giving any sign of a hallucination. It was possible to provoke an attack under hypnosis, and the patient then revealed that he was living through the scene in which his employer had abused him in the street and hit him with a stick. A few days later, the patient came back and complained of having had another attack of the same kind. On this occasion, it turned out under hypnosis that he had been reliving the scene to which the actual onset of the illness was related. The scene in the law court when he failed to obtain satisfaction for his maltreatment.
So you can see every time the rage cannot be expressed, right? He is getting a hysterical attack. Can you see in all these conditions that Freud is describing? That when a negative emotion is generated in huge volume but cannot be expressed, a hysterical hysterical symptom is getting created. In all these cases that he is describing, in the case of the employee, the negative affect we are seeing repressed, right, is rage. In the case of the girl, the negative affect which is being repressed is the fear. Okay. So fear there leads to hysterical symptoms. Repressed anger in the second case leads to hysterical symptoms. Okay. So he describes, yeah, please go
on. In all other respects too, the memories which emerge or can be aroused in hysterical attacks correspond to the precipitating causes which we have found at the root of chronic hysterical symptoms. Like these latter causes, the memories underlying hysterical attacks relate to psychical traumas which have not been disposed of by abreaction or by associative thought activity. Like them, they are, whether completely or in essential elements, out of reach of the memory of normal consciousness and are found to belong to the ideational content of hypnoid states of consciousness with restricted association. Finally, two, the therapeutic test can be applied to them. Our observations have often taught us that a memory of this kind, which has hitherto provoked attacks, ceases to be able to do so after the process of reaction and associative correction have been applied to it under hypnosis.
Under hypnosis, when it is prudently and 360 degree, not 360 degree, but it's prudently, profoundly thought through from all aspects, and when the feeling is let loose, felt and relieved, the correction is achieved. Just a moment. Yeah, the motor phenomena.
The motor phenomena of hysterical attacks can be interpreted partly as universal forms of reaction appropriate to the effect accompanying the memory, partly as a direct expression of these memories, but in part, like the hysterical stigmata found among the chronic symptoms, they cannot be explained in this way. Hysterical attacks, furthermore, appear in a specifically interesting light if we bear in mind a theory that we have mentioned above, namely that in hysteria, groups of ideas originating in hypnoid states are present and that these are cut off from associative connections with the other ideas, but can be associated amongst themselves, and thus form the more or less highly organized rudiment of a second consciousness, a conditioned seconding. If this is so, a chronic hysterical symptom will correspond to the intrusion of this second state into the somatic innervation, which is as a rule under the control of normal consciousness. A hysterical attack, on the other hand, is evidence of a higher organization of this second state. When the attack makes its first appearance, it indicates a moment at which this hypnoid consciousness has obtained the control of the subject's whole existence. It points that is to an acute hysteria. When it occurs on subsequent occasions and contains a memory, it points to a return of that moment. Charcot has already suggested that hysterical attacks are a rudimentary form of a conditioned seconding. During the attack, control over the whole of the somatic innervation passes over to the hypnoid consciousness. Normal consciousness, as well-known observations show, is not always entirely repressed. It may even be aware of the motor phenomena of the attack, while the accompanying psychical event are outside its knowledge.
So we can see how the hysterical state happens. Let us say a person is suffering from hysteria and he has convulsions. So he is sitting with you for 2 hours and everything is going on fine, and something happens which reminds him of that traumatic event, and suddenly he is sitting with you from 12 to 2 o'clock, everything is normal, and exactly at 2 o'clock something happens and he starts having convulsions. So what is happening? Something has triggered that hysterical traumatic event, and that traumatic event has got triggered and become so powerful that it has taken over the complete mental control of that person for a few moments, and the convulsions start happening. So the memory of the traumatic event, it takes the control of the mind for a few minutes or hours during the hysterical attack, and after it is over, the normal control of the person comes back. But during the duration of the episode, the hysterical complex takes over the control of the person. But even when it is so, at times there can be parts of the person who can observe what is going on in the physical body but cannot know the psychological foundation of these physical events. So he says in the last line, very important, the normal consciousness may be even aware of the motor phenomena of the attack, the physical movements of the body, while the accompanying psychical events are outside its knowledge. So we don't recollect the traumatic event, but we can only recollect the physical movements we made during the hysterical attack. Can you see the difference?
So can you repeat that last line? We cannot control. We cannot control what?
Suppose somebody is getting a hysterical attack. Let us say somebody is sitting with you from 12 o'clock to 2 o'clock. Everything is normal. The thing is going wrong. At 2 o'clock something happens, and from 2 to 2:10 he has a hysterical attack for 10 minutes, let us say. Okay. And during this hysterical attack, let us say he undergoes those 4 phases that Freud describes. He had convulsions, he has wide movements of the body, he recollects something, he goes into delirium, and then it ceases. So for these 10 minutes, what has happened? The traumatic memories have taken control of his mind, right? And he is not in his own control. He gets into a disassociated state. He's not in control of himself. And after 10 minutes, when the episode ceases, he again comes back to his normal state where he is in control of himself. Right? Now, if you ask him what happened during that 10 minutes, 2 things can happen. There can be a complete disassociation and he may say, I don't recollect anything. Or second situation may be, he may recollect that he was moving his body in a wild way, but he would not recollect the traumatic event that is still repressed. The traumatic event which is at the root will come up only in hypnosis or deep psychotherapy. It will not come up by the recollection of the person. Very rare that during the hysterical attack, the cause of the hysterical attack also will be known to the person. Very rare. Not impossible, but rare. Yeah. The typical course.
The typical course of a severe case of hysteria is, as we know, as follows. To begin with, an ideational content is formed during hypnoid states. When this has increased to a sufficient extent, it gains control during a period of acute hysteria of the somatic innervation and of the patient's whole existence, and creates chronic symptoms and attacks. After this, it clears up, apart from certain residues, if the normal personality can regain control. What is left over from the hypnoid ideational content recurs in hysterical attacks and puts the subject back from time to time into similar states, which are themselves once more open to influence and susceptible to traumas. So this is when traumas get the same trauma occurs multiple times and it gets collected and becomes a pathology.
And over a period of time, it becomes more complex. The constellation adds to itself. So you may start with only fear of water, and then you may add the fear of crocodile to water, and then you may add the fear of the ship to the water.
Yeah. Okay. Fair enough. Okay. A state of equilibrium, as it were, may then be established between the two psychical groups, which are combined in the same person. Hysterical attacks in normal life proceed side by side without interfering with each other. An attack will occur spontaneously, just as memories do in normal people. It is, however, possible to provoke one, just as any memory can be aroused in accordance with the laws of association. It can be provoked to either by simulation of a hysterogenic zone or by a new experience which sets it going owing to a similarity with the pathogenic experience. We hope to be able to show that these two kinds of determinant, though they appear to be so unlike, do not differ in essentials, but that in both a hyperesthetic memory is touched on. Other cases,
what he's saying here is that either because something related to the traumatic event appears to the person as a stimulus, or some affect is generated, which is exactly like the affect generated during the traumatic event, or some other association, the original traumatic event gets triggered. And when it gets triggered, it acquires all the power and takes the control of the person, resulting in what we call an episode. Yeah, Keval.
In other cases, this equilibrium is very unstable. The attack makes its appearance as a manifestation of the residue of the hypnoid consciousness whenever the normal personality is exhausted and incapacitated. The possibility cannot be dismissed that here the attack may have been divested of its original meaning and may be recurring as a motor reaction without any content. It may be left to further investigation to discover what it is that determines whether a hysterical personality manifests itself in attacks, in chronic symptoms, or in a mixture of the two. It will now be understood how it is that the psychotherapeutic procedure, which we have described in these pages, has a curative effect. It brings to an end the operative force of the idea, which was not abreacted in the first instance, by allowing its strangulated effect to find a way out through speech. And it subjects it to associative correction by introducing it into normal consciousness under light hypnosis, or by removing it through the physician's suggestion, as it is done in somnambulism accompanied by amnesia.
Now what he's saying is, again, the same thing, that the force of the idea and the related affect, the traumatic core, the complex in the unconscious mind, can be removed by allowing the idea to become conscious and allowing the feelings to be mobilized, felt fully, and allowed to let go.
Right. Should I continue?
Yeah, and this can be done in both ways, right? At present, he's talking of doing this thing only under hypnosis, but very soon you will see he will give up hypnosis, and in free association, which is what we do today, right? That in psychoanalytic psychotherapy, the essential thing we do is try to make the unconscious idea conscious and allow the feelings in the unconscious mind to be mobilized, felt fully, and released, so that the person is free from it. Yeah, please.
In our opinion, the therapeutic advantage of this procedure are considerable. It is, of course, true that we do not cure hysteria insofar as it is a matter of disposition. We can do nothing against the recurrence of hypnoid states. Moreover, during the productive stage of an acute hysteria, a procedure cannot prevent the phenomena which have been so laboriously removed from being at once replaced by fresh ones. But once this acute stage is passed, any residues which may be left in the form of chronic symptoms or attacks are often removed, and permanently so, by our method, which it is a radical one. In this respect, it seems to us far superior in its efficacy to remove through direct suggestion, as it is practiced today by psychotherapists.
What he's saying
By
is, just a moment. What he's saying is that during his time under hypnosis, there were two kinds of things. One, people were giving suggestions that in the waking state, you will not get into a hysterical episode when you see XYZ or when you feel XYZ, a direct suggestion method. And second was Freud's method of going to the traumatic event, right? Finding out the unconscious idea, the unconscious affect, and making the person know in the hypnotic state the unconscious idea and the unconscious affect and feel it fully and let it go. Right? So he says that his method of practicing hypnosis by involving the idea and the affect of the traumatic event is far superior to the method of direct suggestion under hypnosis, which was practiced in those days by contemporary psychotherapists. Yes, please. Kyona.
If by uncovering the psychical mechanism of hysterical phenomena, we have taken a step forward along the path first traced so successfully by Charcot, with his explanation and artificial imitation of hysterotraumatic paralysis, we cannot conceal from ourselves that this has brought us nearer to an understanding only of the mechanism of hysterical symptoms and not of the internal cause of hysteria. We have done no more than touch up on the etiology of hysteria, and in fact, we have been able to throw lightly only on the acquired forms, on the bearing of incidental factors of
on the neurosis. So what he is saying here is that we have still not done anything in terms of exact etiological factors, that constitutionally or in the environment, what exactly are the factors we can't describe in exactness, but we have started understanding in a practical way, in a psychological way, how hysteria comes about. And that may be extended to all neurotic problems. Is it clear? With this, we end the preliminary communication.
Yes, sir.
And next time we will take up case history. Before that, we will do one slight diversion and value addition in terms of how Freud's concepts and the Indian concepts run parallel. So we will take up the Rasa theory of the Indian side and try to see how the Rasa theory and Freud's ideas, whether there is an overlap or are they going parallel to each other. Right? And then again come back to the case of NAO. Okay. Any questions you have on today's discussion?
no.
No,
Kiran,
sir.
thank you so much. You have read a long piece today. Okay. So let us stop for the day.
Thank you, sir. Thank you.
Okay. See you then.
All right, thank you. Bye.
See.